Let us discuss about GIT case proforma. So you have to take the patient details: name, age, sex, occupation, address, socioeconomic status, date and time of admission, date and time of examination, and then you need to start with the chief complaints in your history. Chief complaints mainly would be the abdominal distension and yellowish discoloration of the eyes, any pain in the abdomen, any pedal edema. So these will be the chief complaints of your patient. So in GI case, first there is abdominal distension and then it will be followed by the pedal edema. Whereas in CVS case, first there is a pedal edema and then it is followed by the ascites. Whereas in the renal cause, it is first seen in the facial region, facial puffiness. Then the liver failure signs will be seen in the last. So you need to rule out the CVS cause and the renal cause by the pedal edema, at which site and it's occurring. So you need to rule out all this. So in the chief complaints, your main chief complaints would be abdominal distension and yellowish discoloration of the eyes. So then coming to the history of presenting illness, you need to say patient was apparently asymptomatic these many days back and then he noticed fullness or distension of the abdomen, which was insidious in onset, progressed to the present size, and you need to say any association with the breathlessness. Because of the ascites, there would be abdominal pressure, so it will cause breathlessness. Any pedal edema, if it is pitting or non-pitting, mention about the grade. Grade 1 is till the ankle region, grade 2 is till the thigh till the knee region, grade 3 is till the thighs, and grade 4 is anasarca. So you need to mention about the grade and any vomitings and diarrhea if any intestinal obstruction is present. You need to know about the 5 F's, that is fat, fluid, feces, fetus, and the flatus. So, and also you need to tell about if he is mentioning about any abdominal pain, then you need to describe the pain, how was the onset, what is the duration, how was the progression, whether there is a radiation present or not, any aggravating relieving factor, what is the characteristic of the pain you have to say. Then you need to ask for the hematemesis melena, because any upper GI bleed can cause hematemesis melena, variceal bleeding can cause, and you need to ask about the vomitings, nausea, history of any bulky stools, black tarry stools, clay colored stools. So in obstructive or post hepatic jaundice, you'll get the clay colored stools, so you need to rule out, and the black tarry stools will rule out the melena. And history of jaundice, pruritus, any obstructive jaundice will get the pruritus and the jaundice. Any fever with the chills, like you need to rule out the viral causes, viral hepatitis, viral prodrome. So you need to rule out the fever, chills, and history of any anorexia and the weight loss, indigestion, it will point towards the malignancy. And history of orthopnea, palpitations, will rule out the CVS cause. And history of any platypnea is in sitting or the supine position, the patient will get the SOB. So you need to rule out the platypnea. History of any frothy urine will rule out the renal cause. History of hematuria, oliguria also rule out the renal causes. And history of any blood transfusions will rule out the viral hepatitis. History of tattoo markings will also rule out the viral hepatitis. History of any involuntary movements, it will indicate like any Wilson's disease. In Wilson's disease and hemochromatosis, they are very familial, and also the ammonia will concentrate more in the brain. So there will be involuntary movements if there is a Wilson's disease or hemochromatosis. So you need to rule out any history of involuntary movements. Any history of altered sleep, flapping tremors will point towards the hepatic encephalopathy. History of altered sleep will be the primary symptom in the hepatic encephalopathy, and any history of the loss of weight will rule out the malignancy. So you need to rule out all this. First, abdominal distension, then describe about the pain, then describe about the yellowish discoloration of the eyes, if there is jaundice present or not. Then rule out all the CVS causes, renal causes, and hepatic encephalopathy causes, and malignancy causes. And then viral hepatitis, fevers with the chills, and then rule out the blood transfusions, tattoo marks. So you need to rule out all this, and then you need to give a summary. So you have to present like a 50-year-old male patient presented with the abdominal distension, yellowish discoloration of the eyes. So you need to tell about the anatomical, like whether it is pre-hepatic, hepatic, or post-hepatic, obstructive jaundice, non-obstructive jaundice, you need to say, or hepatic jaundice, and what is the etiology. So whether it is due to alcohol, whether it is due to viral hepatitis, whether it is due to if it is pre-hepatic, whether it is due to thrombus. So you need to know about the causes of the liver failure. And then pathological, what is the pathology involved, you need to say about this in the summary. Then going to the past history, you need to mention about any similar complaints in the past, any comorbidities like diabetes, hypertension, TB, hypothyroidism, epilepsy. In all cases we need to rule out the comorbidities, asthma, COPD, CAD. And the blood transfusions will get the viral hepatitis, so you need to rule out the blood transfusions. And family history in Wilson's disease and hemochromatosis, they are familiar disease, so you need to rule out those. So none of the patients or the siblings or the first degree relatives have had similar complaints or any significant comorbidities, you need to mention. And any history of maternal hepatitis B or vaccinated at birth or not, so you need to rule out the maternal hepatitis B vaccinations, because it can cause vertical transmission to the baby, so you need to ask about maternal hepatitis B vaccination or not. And then going to the personal history, you need to ask about diet, appetite, bladder and bowel habits, sleep, and the addictions involve alcohol and the smoking. So drug intake you need to ask about, so you need to say about the cage assessment, you need to know, but you will not take in the patient, so you need to know about the cage assessment. So what is C is, you need to answer the patient, have you ever felt the need to cut down your alcohol consumption? And A is have you ever felt angry at others criticizing your drinking? And G is do you ever feel guilty about excessive drinking? And E is do you ever drink in the mornings, who is the eye opener? So you need to ask about cage. So C is have you ever cut down the alcohol, A is have you ever felt angry, G is have you ever felt guilty, and E is do you ever drink in the mornings? So 2 or more positive answers could indicate a problem of he is a dependent. So the patient could be dependent if they are positive. And then you need to general examination. So 50-year-old patient in supine decubitous position who is moderately built and nourished, is conscious, coherent, cooperative, and comfortably seated lying on the bed, well oriented to time, place, and person. There is no pallor. If icterus is present, mention about icterus, cyanosis, koilonychia, generalized lymphadenopathy, and no pedal edema. And then you need to say about the signs of liver cell failure. What are the signs of liver cell failure? Alopecia, hirsutism in the males, in the females, gynecomastia in the males because of excess estrogen, atrophy of the breast in the females, and palmar erythema, spider navy should be seen in the natural light. And Dupuytren's contracture, cachexia, any weight loss, koilonychia, clubbing, caput medusae, testicular atrophy, hepatic fever is because of the methyl mercaptans that are not metabolized by the liver, because liver is not functioning, methyl mercaptans are not metabolized, so we'll get the hepatic fever. And characteristic sweet smelling breath is a hepatic fetum. So you need to rule out the signs of liver cell failure. And then signs of chronic alcoholism. What are the signs? Parotid swelling, facial flush, Dupuytren's contracture, testicular atrophy, gynecomastia, wasting of the muscle mass. So these are all the signs of the chronic alcoholism. Then signs of hepatic encephalopathy. Early feature could be constructional apraxia. Like you have to ask the patient to draw a star, he will not draw. So that will be the apraxia, that is inability to do the skill activities. And then asterix, flapping tremors. So patient should be in sitting position, conscious, should be able to obey the command. And eyes, you should look for the eyes for the case of Fleischer ring that is seen in the Wilson's disease. And alpha-1 antitrypsin deficiency in the child has respiratory symptoms. Extrapyramidal type CNS involvement with the jaundice, it is seen in Wilson's disease. And C for the KF ring also if Wilson's disease is present. So extrapyramidal type of CNS involvement means there could be involuntary movements like chorea could be there. So that points towards the Wilson's disease. And virtual lymph nodes, supraclavicular lymph nodes enlarged if there is any GI pelvic malignancy. So you need to look for all these signs of hepatic encephalopathy, constructional apraxia, asterixis, eyes for the KF ring. And if there is alpha-1 antitrypsin deficiency, child will be having the respiratory distress. And extrapyramidal type CNS involvement it will point towards the Wilson's disease. So you need to look for the vitreous lymph node also. And then so you have said about the pickle. And then pickle is pallor, ictrocyanosis, clubbing, koilonychia, lymphadenopathy, pedal edema. Then vitals temperature, pulse, RR, BP. Pulse should be said like it is 70 per minute, regular rhythm, normal volume and character, no radio radial, no radio femoral delay, and the condition of the vessel wall is normal. And then BP is 110 by 70 mmHg measured in the supine position in the right upper limb. In the supine position you have to say like the temperature whether it is febrile or ephemeral. And then say about respiratory rate whether it is abdominothoracic or thoraco-abdominal. And then so you need to say in the last, the above mentioned positive history is in the favor of GIT system, hence I have examined the GIT system in this patient. So in what position you will examine for the GIT? the patient should lie supine, and he should flex his legs so that abdominal muscles will relax. Then you need to start the systemic examination of the GIT. First, detailed examination of the upper GIT should be done, like lips, oral mucosa, gums, gingival hypertrophy. Gingival hypertrophy is seen in any leukemia, AML, and blue line on the gums is seen in lead poisoning, perioral papillomatosis, and Gardner syndrome, and oral candidiasis, Peter hepaticus, any halitosis, or it's a bad breath. So you need to look for all the upper GIT, lips, oral mucosa, gums, gingival hypertrophy, any blue lines on the gums, oral candidiasis, Peter hepaticus, and halitosis. Then for abdominal examination, inspection, you need to inspect the 9 regions. So what are the 9 regions? They are right and left hypochondrium, epigastrium, umbilical region, right and left lumbar region, right and left iliac region, and the hypogastric region. Okay, so these are the 9 regions, and you need to divide them by the transpyloric plane and transtubercular plane, and vertical lines or midclavicular lines. So you need to comment about the shape, whether it is scaphoid, elliptical, or the globular. Scaphoid or sunken abdomen is seen in malignancy or any dehydration. So you need to mention. And then distension of the abdomen, whether it is fluid or fetus or fat, feces, flatulence, full size tumor. So you need to tell whether the flanks are full or not. If the flanks are full, it is suggestive of fluid. And umbilicus, what is the shape, position, herniation, any discharge, you need to mention about the umbilicus, whether it is central, inverted, everted is seen in hernia. So smiling umbilicus is seen in ascites, vertical slit like is seen in pelvic tumors. And what movement with the respiration, whether all the cottons are moving equally with the respiration or not. Then skin over the abdomen, whether it is smooth, shiny, because if in the case of massive ascites, there will be a stretching of the skin. So recent stretching of the skin will include will point towards the massive ascites, smooth, shiny, any pigmentation, any engorged veins, visible pulsations, any hernial orifices. So visible pulsations in GI, pyloric stenosis, and visible intestinal peristalsis will point towards the small bowel obstruction. So you need to ask for all this. What is the shape of the abdomen? How is the umbilicus? Whether the distension of the abdomen is localized or generalized, whether the flanks are full or not. What is the movement with the respiration? How is the skin over the abdomen? Whether it is stretched, shiny, any pigmentation, any engorged veins, any visible pulsations, and any hernial orifices are free or not. You need to comment. And then palpation. Start from the areas of least tenderness, with the areas which are less painful, you need to start from there. And pain in the renal angles is pain in renal angles is due to the pyelonephritis. So you need to do superficial palpation and the deep palpation. Superficial palpation, temperature, tenderness, guarding, rigidity, any palpable masses. By superficial palpation you need to mention. So all this: local rise in temperature, tenderness, guarding, rigidity, and palpable masses. And on deep palpation, you can see for the fluid thrill with legs extended. If there is a tense ascites, that is 1.5 to 2 liters of ascites is present, then you will get the fluid thrill. Okay, shifting dullness is seen if it is 1 liter. And then milking test, you need to see for the direction of the flow of the abnormal vein. So in SVC obstruction, it will be towards the caudally to the umbilicus. In IVC obstruction, it is towards the cephalic to the umbilicus. So you need to do the milking test. And any rebound tenderness, if any rebound tenderness is present, any visible peristalsis is present, so you need to check for all this: any rebound tenderness, visible peristalsis. And then organ palpation of the liver. First the palpation should be started in the right iliac fossa, and then you need to feel or palpate the liver, right kidney, and then liver edge, and then aorta, colon, and then the urinary bladder. So so starting from the right iliac fossa. Then in the organ palpation of the liver, you need to comment about edge, extent, consistency, surface, tenderness, pulsation, movement with respiration, insinuation of the fingers under the costal margins, whether it can be done or not. So you need to say about all this: how is the edge, what is the extent of the liver, what is the consistency, whether it is firm, hard, you need to say. Surface, it's smooth or not, any tenderness, any pulsations, any movement with the respiration, insinuation of the fingers under the costal margins. And spleen, whether it is palpable or not. If it is palpable, whether it is any bellotable or not bellotable, you have to say. Normally the spleen is not bellotable. And finger insinuation, you have to comment. And gallbladder, palpable or not. And you need to do measurements. Abdominal girth, you need to measure at the level of umbilicus. So you need to test for the progression of the ascites. and then you need to measure the xiphisternum to the umbilicus and umbilicus to the pubic symphysis distance. Normally the xiphisternum to the umbilicus distance will be increased if it is ascites or abdominal distension, and umbilicus to the pubic symphysis distance will increase if there is a pelvic pathology. Spino-umbilical distance, anterior superior iliac spine to the umbilicus, if both the sides are not equal, then think about the ovarian tumors or any that side pathology you have to think about. So these are the measurements: abdominal girth, xiphisternum to umbilicus, umbilicus to pubic symphysis, and spino-umbilical distance. Now we'll discuss about percussion. In percussion, you need to check for the shifting dullness. It's positive if 1 liter of fluid is present and the patient has to void urine before you perform this shifting dullness, and then do the tidal percussion to differentiate lung and liver pathology. And then organ span should be measured with the percussion. Normal liver span will be 12 to 15 centimeters. If it is less than 9, it indicates cirrhosis. If it is more than 14, it indicates the hepatomegaly. And then do auscultation here for the bowel sounds, and any splenic rub, hepatic rub or the splenic rub will be seen in the perihepatitis or perisplenitis. You will see the splenic rub and hepatic rub and any bruit, and then any venous hum, corbiliar Baumgarten murmur will be seen. Okay, look for the venous hum, bowel sound, splenic rub, and the hepatic rub, and any renal bruit. Renal bruit is seen in renal artery stenosis. So, and hepatic bruit will be seen in hemangioma, hepatocellular carcinoma, hepatic artery aneurysms, and bruit over the aorta can be heard if there is a aortic arch aneurysm. So, look for all the bruits, venous hum, and then bowel sounds, and then examine the other systems like CVS. You have to say normal first heart sound, second heart sound heard, no murmurs. Respiratory, normal vesicular breath sounds heard, no adventitious sounds. CNS, no facial asymmetry, all the reflexes are normal. You have to say, then tell about the diagnosis. So this is a case of decompensated chronic liver disease. Decompensated chronic liver disease with jaundice and ascites with no signs of, if the altered sleep asterixis are present, you have to say signs of hepatic encephalopathy present. If there are no signs, say no signs of hepatic encephalopathy, probably it is secondary to the chronic alcoholism. So you need to say diagnosis like this: this is a case of decompensated chronic liver disease with jaundice and ascites with no signs of hepatic encephalopathy, probably secondary to the chronic alcoholism. Then you need to know the units of the alcohol. 1 unit of alcohol is equivalent to the 8 gram or the 10 ml of the ethanol. So number of units of alcohol is calculated by the volume of alcohol in the liters into percentage of alcohol by volume. So this is a formula to calculate the number of units of alcohol. Males, it is 21 gram per week, and females 14 gram per week. It's a safe limit. And then 1 unit of alcohol is equals to 8 grams. So one small glass, that is 125 ml of wine, has 8% of alcohol. Beer has 250 ml, 4% of alcohol, and 25 ml spirit, that is shots, has 40% of the alcohol. So this is a dosage of the alcohol. And then dose of alcohol causing cirrhosis is, for the males it is 80 to 160 gram per day for 10 to 20 years, and for females it is 40 to 80 grams per day for 10 to 20 years. And then you need to grade the ascites. Grade 1 is detectable on careful examination, plus 2. Plus 1 is detectable on careful examination, plus 2 is easily detectable but of small volume, plus 3 is obvious ascites but not tense, plus 4 is tense ascites. So this is a grading of ascites. Plus 1 is detectable but on careful examination, plus 2 is easily detectable but of small volume, plus 3 is obvious ascites but not tense, plus 4 is tense ascites. So shifting dullness is seen if it is 1000 ml, fluid thrill is seen if it is more than 2000 ml, puddle sign will be seen if it is 120 ml. Then what is a Courvoisier's law? This states that in the presence of jaundice, a palpable gallbladder makes a gallstone obstruction of the common bile duct an unlikely cause. It is not due to a palpable gallbladder is not due to the gallstone obstruction, because it is likely that the patient will have had gallbladder stones for some time, and these will have rendered the wall of the gallbladder relatively fibrotic and therefore not distensible. So it will not make gallbladder distensible. However, the converse is not true, because the gallbladder is not palpable in many patients who do turn out to have malignant bile duct obstruction. So normally in the Courvoisier's law states that gallbladder is not palpable if it is because of the gallstones. It is palpable if it is because of the any carcinoma. So in the carcinoma, gallbladder carcinoma, it is palpable. In gallstones, it's not palpable. So this is about Courvoisier's law. And in palpation of the liver, you have to say character of its surface, whether it is soft, whether it is smooth, tender. Tender is seen in heart failure, very firm or regular. Firm and regular is seen in obstructive jaundice and cirrhosis. Tender in the heart failure. And hard, irregular, painless, and sometimes nodular. It will be seen in the secondary carcinoma. So you need to mention about how is the liver. Soft and smooth and tender is seen in heart failure. Very firm, regular is seen in obstructive jaundice and cirrhosis. Hard, irregular, painless is seen in secondary carcinoma. So in tricuspid regurgitation, the liver may be felt to pulsate. So pulsations can be felt on the liver because of tricuspid regurgitation or tricuspid stenosis. Occasionally, a congenital variant of the right lobe projects down lateral to the gallbladder as a tongue-shaped process called Riedel's lobe. And though uncommon, it is important to be aware of this because it may be mistaken either for the gallbladder itself or for the right kidney. We may mistake as. So you need to know about the Riedel's lobe, which is a congenital variant of the right lobe that projects lateral to the gallbladder as a tongue-shaped process. And you need to know about the Child-Pugh score to assess the prognosis of the chronic liver disease. And then you need to know about the West Haven classification of the hepatic encephalopathy. Stage 1 is euphoria or the depression, mild confusion, slurred speech and sleep disturbance. Stage 2 is lethargy, moderate confusion. Stage 3 is marked confusion, incoherent speech. Patient is arousable from the sleep. Stage 4 is coma. So asterisk is seen in all the first 3 stages but not in the stage 4. EEG is normal in the first stage but in all the 2, 3, 4 stages it is abnormal. So you have to know about the West Haven classification of the hepatic encephalopathy and how is the liver. When you palpate on a soft, smooth, tender liver is in heart failure, firm, regular in obstructive jaundice, cirrhosis, hard, painless, irregular is in carcinoma. So you need to know about grading of the ascites, +1, +2, +3, +4, shifting dullness, fluid thrill, Puddleson and Carvoiser's law you need to well aware of, and you need to know about alcohol, smoking years, and how you'll check for the 1 unit of the alcohol. 1 unit of the alcohol is equivalent to the 10 ml of ethanol or 8 grams of ethanol, and number of units of alcohol is equals to volume of the alcohol in the liters into percentage by the volume. Percentage by the volume is ml by 100 ml. So you need to get like this. So this is about the GIT case proforma. So first, chief complaints, history of presenting illness, past history, family history, personal history, and then general examination, signs of liver failure, signs of hepatic encephalopathy, systemic examination, upper GIT, per abdomen, 9 regions examination, on palpation, superficial deep palpation, and then on palpation you need to mention about the measurements and percussion, shifting dullness, tidal percussion and organ span, and auscultation, bowel sounds, bruit, hepatic rub, splenic rub, and venous hum, and other systems examination. Then you tell about the provisional diagnosis as a case of decompensated chronic liver disease with jaundice and ascites with no signs of hepatic encephalopathy, probably secondary to the chronic alcoholism.